So we have the privilege today of having Tim Clement and David Lloyd. Tim is the Regional Director and Legislative Advisor for the American Psychiatric Association, and David is the Senior Policy Advisor for the Kennedy Forum. They're each going to talk about parity at the state level for about 15 minutes, and we'll open it up for about 15 minutes of questions at the end. You'll be passed out note cards, and we just ask that you write your questions down on that. We'll collect them, and if you have a specific question for one of our speakers, we ask you to put their names down on that. And so I will defer over to Tim.
Okay. Well, thank you very much. It's a pleasure to be here, and so glad to see a packed room. So the topic, we're obviously talking about is parity at the state level. I'll give a little, just a background of what's been going on over the last year or two. The last 14, 15 months in particular, I've seen a lot of action taking place in the states, a lot of good action. I'll talk about what we've been seeing right now, what are some things that have worked in terms of just talking to legislators about the issue, because it's going to be a very complicated issue. And then I'll just briefly touch upon some of the pushback you might get in your states on if you're trying to go in the legislative front or if you're trying to work with regulators. So obviously, I think just to level just a 30,000 foot, it's good to talk about what parity means exactly, because a lot of times, I talk to people, and while people understand that there's this thing called parity, sometimes it's a little unclear what exactly does that mean. Well, the law itself, the concept itself is very simple. Insurance coverage for mental health and addiction should be no more restrictive than insurance coverage for any other condition. And I think it's what I've learned over the last, I've been working on this issue for about 5 years now. What I've learned over the last 5 years is you want to make sure that that's how you talk about it, and you make sure that legislators and their staff understand that you're talking about a very simple concept. Insurance coverage for mental health care should be no more restrictive than insurance coverage for anything else, period. And that's it. Now the law itself, the federal law and many state laws are quite complicated and dense with very complex terminology, but that's not really so important when you're talking about it, what the actual mechanics of the law. It's just important that legislators, in particular, and their staff understand that it's a simple concept. And the reason that there's a law, and there needed to be a federal law, is because historically that has not been the case. Because of discrimination against individuals with mental health conditions, insurance coverage was very restrictive for mental health care, and it still is restrictive. And I think that's what you need to. That's what you want when talking to legislators about this topic. It's there's a law that says insurance coverage for mental health care shouldn't be more restrictive, but it still is, and that's why I'm here talking to you, because we need to do something about that. And then I think some of you that I've worked with before, the words you really want to focus on, if you're talking about additional parity legislation, is we don't need to talk about parity now. We need to talk about transparency and accountability. Transparency and accountability is really, if you're talking about additional legislation, that's where it's at. Because that's the question you're going to get. Let's say you're in your state and you say, oh, well, we have parity legislation that I'd like you to pursue. If you're talking to a legislator, they're going to say, well, don't we already have a parity law? I mean, I remember one time when I used to work for the Kennedy Forum, I met with a legislator who ended up being the sponsor of the bill that passed in New Jersey. And he knew who I was, and he said, parity, isn't there some sort of Kennedy that passed a law about parity in a few years? Because yes, that's right. He says, well, why do we need another law? And so the answer is we don't need more parity, we need accountability and transparency with the parity law that already exists. And that's something that I don't think any legislator in the world, in any country probably, is against transparency and accountability. And especially right now, those are buzzwords throughout state legislatures here in Congress as well. So that's what you want to talk about when talking to legislators about this issue right now, is that if you're talking about legislation, we really want to make sure that insurers are transparent and that they're also accountable to the individuals and business owners that are purchasing these health insurance plans and making sure they're getting what they pay for. And that's messaging that really speaks to both parties. So what's been going on with parity over the last 14, 15 months, last few years, is that the Kennedy Forum, the APA, had created model legislation that would basically require insurers to be transparent, to perform analyses that would demonstrate how it is that they are or are not complying with the more complicated aspects of the federal parity law. So they perform analyses and submit them to state regulators. And then that legislation also has components that require state regulators to do enhanced oversight. And also one other thing you want to say when talking about parity with legislators, well, where are the problems right now? And the problems are where the insurers, their managed care practices. So things like when they do a prior authorization, or how they design their provider networks, or the exclusions of certain benefits, or how they set reimbursement rates. Those are the issues where state and federal investigations are finding lots of problems. So that's where insurers need to be transparent about how they're designing and applying those practices. So that's what these legislative efforts have done over the last 50 months, is require insurers to do analyses demonstrating how they're designing and applying their managed care practices, and also requiring regulators to enforce the law. And so legislation has now passed in the last 15 months in Connecticut, Colorado, Delaware, DC, Illinois, New Jersey, and Tennessee. And a number of other states, and I know that some of you in this room have been involved and have pursued legislation, like Florida, Mississippi, California, Minnesota, Missouri, and a number of states have introduced bills. And we think there's going to be a lot more states that continue to pursue legislation. And one thing that and I'd be happy to send a link around to everyone. One thing that we, the American Psychiatric Association, have done is we've adapted the Kennedy Forum model legislation to all 50 states. So up on our website, we have drafts of legislation that look exactly like pieces of legislation look in your state. They amend the right sections of state law, they use the right terminology, they use the right formatting, and even the right font type, and so forth. So all you'd have to do is download it and just hand it to a legislator and say, just put your name on this. But quite literally, it has, it says senator, and then there's like a little line. You could put the senator, put their name on it. But that's something that's been going on. We expect that, one thing that when I worked for the Kennedy Forum, I helped launch a website called Parity Track. It's paritytrack.org. And when I was doing that, I also tracked state autism mandates. So over the last 10, 12 years, basically every state in the country, except I think there's 2 or 3 that still haven't, passed a mandate requiring insurers to cover autism services, which is something that they shamefully did not often do before that. What I saw with that is, you had a state here or there pass the bill in 2007, 2008, then 2009, 2010, a few more states passed the bill. Then by 2012, 2013, states were just tripping over themselves to pass and introduce and pass these pieces of legislation. I think something similar is probably going to be happening with the parity legislation. I mean, now that you got 7 states, I think by the end of this year, we might get up to about 10. You're going to see, I think, the floodgates open. And then one thing that state legislators like is when you have a model that other states have pursued and passed, and that's the thing I should note. These pieces of legislation have been very bipartisan. Usually you have both Republican and Democratic sponsorship, and most of them have been either unanimously approved or very close to unanimously approved. So that's something when you can offer a legislator something that one has passed, has worked in other states, and has been bipartisan. That's something that legislators love. They love bipartisan solutions that are they're not reinventing the wheel. So in fact, you should use that term. You don't need to reinvent the wheel. We have it for you. These other states have done it, and you list the states that have done it. So I think that's something that we've seen. We're probably seeing some more action. Just want to note pushback that you might get. So that obviously the opponents of these kind of legislative efforts are going to be the insurance industry. And I think when talking about it, you don't want to frame the insurance industry as the bad guy, like they're evil or they're doing something wrong. You want to say that they've been doing a good job complying with the more simple components of the parity law, but they're having a little trouble with the more complicated aspects of the law. And then what you want to do is say, we're not trying to make them cover this or make them cover that. This is just about having them show their work. Showing them what they're doing. What the insurance industry will say is oh, this is burdensome, this is onerous, this is difficult, this is going to cause premiums to rise by 5,000%, that kind of stuff. And what you need to say is, and this has been effective saying this, is that the only way this would be burdensome is if they haven't done their due diligence to check if they're in compliance with the law. Because the law is a comparative law. The only way you can know if insurance coverage for mental health care is no more restrictive than insurance coverage for other medical care is if you've compared the two. That's what the law requires. So the only way you can compare things is by doing a comparative analysis. So asking them to perform comparative analyses is kind of like asking them to do what they should be doing already. And that's something that once you say that, so when they say this is going to be onerous, this is burdensome, you can say, well, the only way it'd be onerous and burdensome is if you hadn't done what you're supposed to be doing already. And that's, I've yet to hear an insurer come back with a really good comeback to that one. So I would say just be ready for that pushback and then say that this really shouldn't be onerous or burdensome. And then, you don't need to get too deep into the details, and you just say this shouldn't be onerous and burdensome, and this is just about making sure people are getting what they pay for. So I think that's sort of what the landscape has been and what's been working. And then one thing I should say is also, don't forget about your state regulators. Your state insurance department, that's the entity that's responsible for enforcing and regulating private health insurance plans in the individual market and the small employer and large employer market that purchase plans from an insurance company. So, I think one thing that my colleague, Sam Muzinski, and I, we work with a lot of state insurance departments, and we provide trainings to them. And one term that Sam uses, and not in a pejorative way, is the term Parity IQ. Now, right now, Parity IQ is relatively low in insurance departments, but actual IQ, from what I found, is very high. You have a lot of smart people working in insurance departments, and they're very they understand this is an issue that they need to pay attention to. They realize that there probably isn't full compliance with the law. I don't think you have to convince too many regulators anymore that that's a problem. So, I think that meeting with your state insurance department, just letting them know that this is an important issue, that is very important to suicide prevention, and also addressing the opioid epidemic. That's one thing I should note, that everyone wants to solve the opioid epidemic, and this is what you can say about the Parity law. Parity is a way you can address both problems at the same time. You can address suicide prevention and the opioid epidemic with this law. But I would recommend meeting with your insurance department. Some of your insurance departments are already probably doing something on this or thinking about it. Some of your insurance departments are not thinking about this right now but want to think about it. And some of your insurance departments, sadly, don't want to think about this at all because they see their job as making sure insurance companies operate efficiently and make money. So I would think, though, but it's definitely worth it to just check in with them. The insurance department is going to be, if there's any legislative efforts, the insurance department is going to be consulted and talked to. So if they've heard about it from advocates or had conversations before, I think that's something that they'll be glad to meet with them. And then, I would pledge, if you do meet with an insurance department, they say, well, what can we do next? Volunteer Tim Clement from the American Psychiatric Association. You can get in touch with him and his colleague Sam Muzinski. They do free trainings for insurance departments. Most of these insurance departments probably, they know me or have heard of me because I've presented at the National Association of Insurance Commissioners. But that's something that we do provide for every state insurance department that wants it. We provide technical assistance. We have tools that they can use for performing market conduct examinations on insurers. So that's something, if you have an insurance department that's very interested in doing more, but they know they don't know enough, we're very happy to provide them with any kind of technical assistance that they would need. So I know I don't want to take up too much more time, but I think that those are the key things. I think there's a lot of action in the legislative front right now. I think you've got a good opportunity to say, look, I've got a bipartisan solution that is going to help address the suicide crisis and the opioid epidemic. And then also meeting with regulators too, because they have, ultimately, that's the one last thing that I'll say is, we won't have full compliance with the law if regulators don't do their job. Ultimately, they're the cops. They're the ones that check to see if there's actually compliance. So we can pass all the legislation in the world, but the regulators are going to need to get up to speed. So just keep that in mind. So you need to pursue both prongs. But anyway, I'll wrap up there. I don't want to take up too much more time.
Great. Well, thanks, Tim. I'm David Lloyd with the Kennedy Forum, and Tim gave a really good overview, kind of the basics of Parity and the Parity legislation that both the Kennedy Forum and American Psychiatric Association have nationally. I want to focus more kind of on political pressure and kind of how you build political pressure in your states that is necessary both to pass legislation like this, but also, as Tim kind of mentioned at the end of his remarks, putting pressure on the regulators to actually do their job and enforce federal and state parity laws. Because I've worked a lot, done a lot of work in Illinois, and we have a very strong parity law that worked to pass in the past couple years. And that law is now in the books. But frankly, if I don't do anything at this point, nothing will happen. So it's incumbent upon us to keep up the pressure now that we have a strong law. So I think that there are a couple key components to this. One, I would encourage you in your states, and I think basically every state that has been really successful has had some type of coalition that's been pushing the parity legislation. It's very, not to say that one organization can't do it by itself, but it's very helpful to have a broad range of organizations, including your AFSP chapter, as well as other behavioral health organizations, the NAMIs, MHAs, et cetera. That can be really important, and at key moments, those stakeholders can weigh in and kind of get legislation across the line. So in Illinois, I run the coalition in Illinois currently, and we actually, despite having passed a law last year that's now been enacted, we're still meeting on a regular basis to make sure that the law is implemented in the way that we think it needs to be. The other thing that I think is really critical for you to focus on, and for the coalition to focus on, and I should say that a coalition doesn't have to be, it can be kind of informal. It doesn't have to be, you don't have to think it's a huge project to take on. It's really just getting people together to try and move these issues forward. But really defining what the problem is, I think, is really critical with lawmakers. And I think this is where also the press can be your friend. That really gathering together some stories of people who have been wrongly denied care, and kind of the consequences of those denials can be very powerful. And in Illinois, when we were pushing the Illinois law, we actually had someone who was an AFSP member who had lost their son to suicide, and who was amazing, working with press and really giving our efforts real momentum, to enact the legislation. The other thing I would also say is that you should try to kind of ground your efforts in some data, and there's one kind of key. At this point, kind of seminal report by the actuarial firm Milliman, and they have state data that they looked at over 40 million claims from across the country, and they looked at out-of-network usage for behavioral health care versus medical surgical claims. And essentially what they found is in every state across outpatient, inpatient care, that they out-of-network usage was much higher for mental health and substance use disorders than for other types of medical conditions. Which basically the takeaway from that is that in-network coverage was inadequate, that people couldn't get the coverage, the care covered in-network for mental health and substance use disorders, so they were going out-of-network. Because no one would really voluntarily go out-of-network if there's an in-network provider that they can access, just because of the different out-of-pocket costs associated with that. So that is, I think, a key piece of report to look at. And on the Parity Track website, it's broken down by state, the state data. It's also worth kind of looking at the report itself. You can find that on the Parity Track website, or I think if you Google Milliman and NQTL, I think that report will probably come up.
How do you spell that, Milliman?
It's Milliman. And so I think having the personal stories is really important. Grounding it in data so that the combination makes it hard to dismiss. If you just have data that that's kind of dry, it doesn't really tell the story. And just having the story, you don't want legislators to kind of dismiss it because this might just be an anecdote. So I think really combining the two is really important. Another thing that we did did when I was leading the efforts in Illinois is we actually surveyed, the coalition surveyed behavioral health providers across the state through the major behavioral health associations. So we had the Illinois Psychiatric Society, we had the Illinois Association for Behavioral Health, basically all the trade, all the trade groups who represented providers. We did a survey based on kind of how often they were seeing denials for mental health and substance use care, and we issued a report which actually drove a lot of press and was essential as kind of a lead behind, or talking to legislators about these issues. So that can be another kind of tool in your toolkit that takes some effort, but I think you can it can be it can definitely be helpful. But more broadly, I do think it's critical to build. Really focus, in addition to the transparency, the accountability is key. And the transparency enables the accountability, but there also has to be continued efforts with regulators and also legislators as well to make this issue a priority. If we don't actually press and insist that this be made a priority, it often isn't. And where we've seen the most success is where there's been coalitions who are really making this a priority and defining the problem, and then the transparency and accountability through this legislation, really is then the solution to that problem, and it becomes you can gain a lot of momentum. But as I mentioned, even after you pass legislation, the work isn't done. Because the regulators have a lot of leeway in what they do. So the legislation increases transparency, but if there's no one actually watching to see what that transparency actually illuminates, then the regulator can essentially do nothing. So that's where continued advocacy with your partners, I think, is really critical. And so one last remark, and then I think we can probably open it up for questions, is it's tempting just to focus on commercial insurance, which is absolutely critical, but I don't think we can forget Medicaid in our states. That if you forget Medicaid, you're leaving out a huge population, and frankly, those populations, since Medicaid serves low-income individuals, those are the populations most at risk in terms of kind of the social determinants of health. And so don't forget Medicaid, and don't forget your Medicaid agencies. It frankly can be a little bit complicated, so if you need help with the Medicaid aspect, definitely reach out to me, reach out to Tim, in how you can work with your Medicaid agency to make sure that they're that the Medicaid managed care organizations who most states use are in compliance with Parity. I think, frankly, it's pretty abysmal right now. Most Medicaid MCOs, managed care organizations, in their compliance with Parity, and there's basically no one besides our organizations who are really looking at this really closely and trying to demand some accountability. So I would definitely encourage you to include Medicaid, if possible, in the legislation, but also in the advocacy efforts. Definitely meet with the Medicaid agency with you and your partners. And then kind of one last remark would be that obviously you need to take stock of what the political situation in your state is. Every state is different. I mean, this is a bipartisan issue. I think this tends to be easier in more liberal states. And that also means you can pass this bill more easily, but you can also, if there's an opportunity, you can also look at other areas of your insurance laws that need to be strengthened and include additional provisions as well. And one good example of that is Colorado, who's been kind of a purple state for a long time, but now is in Democratic control. Passed very comprehensive legislation that includes its transparency provisions, but they saw windows to add other provisions as well, so they did so. And I think it was a month-long process that they worked on this bill, and ultimately got passed and got signed into law just in the past month or two. So definitely look at the political situation in your state. Find the right champions, find bipartisan champions, because I think that's really critical. But I think Tim is right that there's a lot of momentum, and we can continue to push to really make parity a reality more than 10 years after the Federal Parity Act was passed into law, which our founder, former Congressman Patrick Kennedy, I think, who we heard from on Monday, was the sponsor of. So we thank you for all your efforts and for your interest in what is admittedly kind of a wonky topic.
Thank you, David. Thank you, Tim. You can all give us some applause. Yeah. Thank you for the work that you're doing. Thank you for sharing your expertise. If you have questions, we ask that you hold them up on the note cards, and Peyton can collect them for you. And we'll read them out loud.
In the meantime, you spoke to NQTLs. For those who may not be familiar, could you explain what NQTLs are?
Yeah, so the acronym NQTL stands for Non-Quantitative Treatment Limitation. And what that means is that's if you're a parity nerd, that's where all the action is right now. But if you're a normal human being, that's sort of a meaningless term. But what that refers to are those managed care practices that I talked about. Like, so if an insurer is going to do a prior authorization, let's say someone's in an emergency department with suicidal ideation, they want to be transferred to an inpatient facility. Insurance company says, let's do a prior authorization to see if that's medically necessary. That falls under the realm of non-quantitative treatment limitation. So do things like geographic restrictions, or we don't cover residential treatment, or things like that, and also things like out-of-network usage, like David was referring to, how insurers design their networks and how they maintain their networks. That's something that falls under that term. So if you're looking at parity legislation, they'll all have that term in it, non-quantitative treatment limitation. That's definitely a term you want to avoid using when speaking to legislators or the media or living, breathing human beings. You want to avoid that term. I try very hard to avoid the term now, because I realized the first time I ever gave a presentation on parity, I said, okay, non-quantitative treatment limitation, or NQTL. Anyway, NQTL is and then like 15 minutes later, I was like, oh, I made a really bad mistake in using that term. So yeah, but it's the key term, but it's something that is best to be avoided. But know that it exists, and if someone were to bring it up with you, because you will have some legislators and some very smart staff that do know the term and have looked up on it, and they'll say, well, what do you mean by how are we doing on NQTLs? And so you want to be ready for it, but if someone doesn't bring it up first, I wouldn't recommend bringing it up.
Okay, there's a question about kind of, are there ways for litigation attorneys to volunteer to assist in parity enforcement actions against non-compliant insurers? Yes, I think the answer is yes. So the Kennedy Forum has a legal task force of attorneys who are working on these issues across the country. And who take parity and related insurance cases. So if you're interested, please. I think the best way is just to right afterward, just talk to me. But I think there are ways for litigation attorneys to work on these issues. And litigation, I think, is actually is a critical piece of the puzzle of how we make parity reality. And actually, I see that many of you have, although it wasn't strictly a parity case, the Witt versus United Behavioral Health decision was very important, because it really outlined a way in which the largest managed behavioral health care company in this country was not following generally accepted standards of care for mental health and addiction. Which is very powerful, and I think if you actually read through the decision, there are hints at possible parity issues, throughout. But that was a class action federal lawsuit, that was brought in the Northern District of California.
And one thing to echo on that Witt decision, while technically it wasn't parity, I think it's very easy to, because I think a lot of legislators are aware of that decision now. You say, look, this is an example of a major insurer having major problems with how they do their mental health benefits. So I mean, that's the way to pivot it and say that's why we need to look into what insurers are doing, because they've had serious problems.
Yeah, and just a follow-up to that. I mean, I think you can, in the kind of the messaging, the talking points that you use, essentially at this point, every major insurer in the country has been found to have violated parity in some way or another in different states. And so you can point to that as kind of evidence of the problem. And we can get you those specifics if you're kind of interested in kind of, in Pennsylvania, I think Aetna was fined, a very small fine, but still fined, $150,000. There was a big, in Rhode Island, there was wasn't a fine exactly, but a $5 million kind of as part of a settlement with the Rhode Island Insurance Commissioner. So, there are many examples of noncompliance that you can cite.
And it may be useful to note that that Witt decision, even though the decision comes from Northern California, was a nationwide issue.
That's
So
right.
they found both general violations and then specific violations within states themselves. certain states.
Yeah, so that's right. And I think also what I've been saying the last few months to members of Congress that helped us get a federal bill just introduced by was that basically, this is what I say is like, well, basically every state and federal investigation that's looked into this has found problems, and the mantra among regulators now who work on this is, if you look, you will find problems. So I think that's something you can use, that quote right there. If you look, you will find problems, and that generally seems to resonate with staff and legislators as well. Question I got just to reemphasize, which 7 states have passed legislation to enforce the parity law? So those 7 states are, and I'll do this in alphabetical order, hopefully. Colorado, Connecticut, Delaware, District of Columbia, Illinois, New Jersey, and Tennessee. So that's Colorado, Connecticut, Delaware, DC, Illinois, New Jersey, and Tennessee.
Okay. There was a question about how can we find out how our state ranks. So the Kennedy Forum last October released a state parity scorecard, which just looks at state statutes. That is on paritytrack.org. And the vast majority of states received a failing grade based on that metric. It looked both at kind of the expansiveness of the state parity laws, which is important for you to actually look at, in addition to kind of transparency. Are there key gaps in our parity laws that we need to fill? And either Tim or I could be helpful with you on those aspects. But it looked at kind of how comprehensive our parity is your state's parity laws. It looks at transparency and accountability. And a key aspect of the kind of the transparency legislation that we've been talking about is actually the state regulator reporting to, the state regulators reporting to the legislature on kind of what they're doing. Because that's a key aspect of the transparency. So it's not only health plan transparency, it's regulator transparency on what they're doing to enforce the law.
Another question it had for me is, where can we find the sample parity legislation to download? So that's on so the website is psychiatry.org. It's kind of difficult to find it on our website, and the actual hyperlink is pretty long. So what I would recommend is, if you want to, is to email me, and I'll give you my email address. It's T. Clement, so that's the first initial of my name, Tim, last name Clement, C-L-E-M-E-N-T. So that's TCLEMENT at psych.org. And that's PSYCH. .org. And so I can email you the link. I can just email you a draft, if it's for your state, I can email you a draft version of the legislation. And what I did is I created 4 versions for each state. So one is like a comprehensive version, and then there's one that just has reporting requirements for insurers, and there's one that just has enforcement and reporting requirements for the insurance department. And then there's another section that I added onto the comprehensive version, which I've sort of reconsidered, is a section that addresses coverage of medication-assisted treatment for opioid use disorders, because that's, again, the opioid epidemic is something that everyone wants to solve right now, and I saw that as a potential sweetener for legislators. And that actually has worked. But the insurance industry hates that a lot more than they hate the parity reporting stuff. So my recommendation at this point is probably to keep those things separately. And also, especially since your issue is suicide, it would seem like a bit of an awkward fit. So I can email you versions that don't have that in it. So again, so if you want those pieces of legislation, you can email me at tclement@psych.org.
Well, it's funny because we use the legislation in Illinois, and my only comment, and I agree with Tim, but the only comment is that there are situations, because we kind of traded, we actually traded some provisions for buying, if you are in a good environment in your state where you think you can get a lot and have a good sponsor, by having a comprehensive bill, a lot of times these bills don't necessarily, there's some negotiation that goes on. And so if you can have provisions that you're willing to kind of trade away, having a more expansive bill that's moving, and then you can protect the core of what you want. So that's the only comment I would make.
Yeah, that's a good point. In fact, so if you're working in a coalition where people have good relationships with legislators, and you've got a good degree of clout, and you can get to the table, sit there, and talk. Absolutely, you might want to push for more than you think you can get, because you trade it out. In fact, that's what we did in Connecticut. Initially, we had those medication-assisted treatment provisions in the bill, and we had to knock down, drag out, fight with the insurance industry, and we made very superficial, inconsequential changes to the parity language. And they were like, okay, that's the parity. That's fine. We'll do that. But we can't have step therapy for medication-assisted treatment. And then so finally, what we did is we just pulled all the medication-assisted treatment stuff out of the bill. One, to not agree to anything that was less than ideal, and then two, that helped us get the bill over the finish line. So if you're in a position where you can negotiate, I would absolutely recommend putting as much in there as you can to then negotiate some of the stuff out that maybe you don't think you can really get. But if you're just in a situation where you think you can only present something to legislators and it's sort of a take it or leave it, you might want to, so just it depends on what your situation is and how much negotiating power you have.
So there was a question about how is mental health parity and/or overall access in other countries with different healthcare systems. I don't know, i.e. Canada, Denmark, or Sweden, I don't know that I have kind of the first-hand knowledge of this. I mean, I think in many respects, it's probably my own just personal opinion, but other healthcare systems in terms of insurance are vastly superior to ours. So insofar that I know many other countries have good mental health and addiction coverage under their state single payer system, and so parity doesn't kind of align in the same way as in our unique context.
Yeah, and I think David's generally right about the other countries in terms of how they might be superior. However, I do have very secondhand knowledge of this. Former Kennedy Forum alumnus Amanda Mowry, when she was in graduate school and working as an intern for the Kennedy Forum, she did a paper examining parity in UK, Canada, Australia, and I think New Zealand. And what she found is it's very, very different how they think about that in other countries. Like, for instance, in England, they call it parity of esteem. I'm not sure why they call it that, and it's more about, they think of parity, and maybe I'm confusing, this is Australia actually, but in Australia, they think of parity in terms of just parity generally for all types of different insurance, like life insurance, disability insurance, and they don't focus it just on health insurance. And in Canada, they think of it somewhat similar to us. But anyway, the not having done the work myself, I don't want to speak too much about it, but they have very different conceptions of parity in different countries. So it's very interesting how they think of it.
Okay. There was a question, does parity apply to things like Social Security, Medicare, and then says specifically when someone gets denied benefits for mental health issues. So unfortunately, the Federal Parity Act does not apply to Medicare, and also doesn't apply to Medicaid fee-for-service, which is an important issue, although with the rise of Medicaid managed care, which Parity does apply to, that means fewer people are in state Medicaid fee-for-service programs. It doesn't apply to Social Security because Social Security is not really a health insurance, health insurance program. Tim did mention disability insurance, which is actually a big issue across the country. It's kind of a separate issue, but there's no parity for disability insurance. So if you are disabled due to a mental health or substance use disorder, they have, most insurance policies have lifetime caps of, I think, 2 years. And that's completely legal in every state in the country.
Yeah, and that's it. That is, and there's a few states I've seen in Massachusetts they've introduced parity disability bills in the past, and I think there's one right now. But that is probably a next frontier is addressing that. And then just getting back to Medicare, with the APA, that's going to be something, probably not this Congress, but the next Congress that we really focus on is, there's that conversation, obviously, that some have about, Medicare for all. And I think that one thing that we're very concerned with is, well, if Medicare for all, Medicare is by far the worst payer for mental health benefits. So, and that's something to make sure that whenever you talk to someone who talks about Medicare for all, you always need to say, well, you do realize Medicare has the worst mental health benefits of any payer in the country, and that really needs to be improved. And you don't have to weigh in on what you feel about Medicare for all, but just say, I think that's something that's important that people realize is that Medicare needs to be dramatically improved for mental health care, and that includes extending the parity law. There's a horrible 190-day lifetime limit for treatment in an inpatient facility, and there's a lot of services they don't cover at all. So just make sure that that's on top of mind. Medicare is not good for mental health care.
Yeah, no, and we completely agree with that. I would say that Medicare for all has kind of become a slogan. That if you actually look at the details, it's not clear that it actually means expanding Medicare for all. It's become, it's kind of become sloganized. So, but I think it's definitely a point worth making.
Will this include coverage for inpatient therapeutic programs for youth that do not only administer medication, but rather programs that offer more holistic approach?
Sorry. So yeah, I think, and I'll also let Tim can help with this. But if I understand what it's saying, it's all about this. Parity is all about this comparison between mental health and addiction coverage and medical coverage broadly. So when different types of care are not covered, you have to look at it's fundamentally about that comparison. So I think there is a movement to have to cover more of these holistic, and I think oftentimes outdoor behavioral health is mentioned in this context, and so it's an open question about how successful the parity law will be at increasing, aspects, increasing access to coverage for some of these, I guess, what might be called kind of alternative therapies.
Yeah, and I think that's, basically parity applies to anything when it relates to your mental health coverage. So anytime you're encountering any sort of denial or restriction on care for your mental health, remember the parity law could very well protect you. And it's not necessarily just because you do encounter restrictions or barriers to care. That doesn't mean it is a violation, but again, the burden shouldn't be on you to figure out if it's a violation. The burden should be on the regulator and also the insurer to figure out how it's a violation or how is it not a violation. So if, like, for instance, you do have this holistic care and they're saying, well, we don't cover anything that's provided outdoors or something like that, or we don't provide anything that involves this kind of therapist. Say, okay, well, how did you determine that? And then, how does that comply with the parity law? And the answer that they'll have is, we determine that because that's how we determine that, and we haven't thought about that at all. But getting them to basically have to say that internally, and they'll say that back to, like, I work with regulators, and a lot of times that's something that you see. The insurers will say, well, we don't cover that. And it's like, well, you have to have a reason for why you didn't cover a particular service. If you're, that's something to understand, that any service that's excluded for, let's say, we cover this condition. So we cover conditions, people with, eating disorder. We cover conditions for people with depression or schizophrenia, but we don't cover this specific service. That's something that could be a parity violation. When you make a determination that you're not going to cover a particular service, that has to meet the rules of the law, and oftentimes insurers haven't even thought about that, and when confronted with, like, oh, you mean we have to follow the law when it comes to that? And it's like, yeah, you do. And we got one question here. I'm not sure I totally understand, so if whoever asked this can come up and talk to us offline. It's an activation request. If it has been denied 3 years, should we rewrite the request to activate? I'm not totally sure what that means, so whoever asked that, if you could just come up and after this and just ask, and we can try to help you.
Perfect. Thank you again for sharing your expertise with us. Let's give him a hand. I wish we could keep you longer, but this is being filmed right now for all of your references. And thank you again.
Thank you.